Hello, Nav Cavale here, plastic surgeon. Welcome to the Real Clinic podcast, sponsored by 42 South Films. This is where we take a behind-the-scenes look at the surgery industry, get to meet key players in the business, learn about setting up a clinic such as Real, and meet some of the best surgeons around. Hi, and welcome to another episode of the Real Clinic podcast, and thank you very much for joining us. And today I have another great guest, Mark Solomos, who's a fellow plastic surgeon.
Hello.
And we've worked together for too long. But thank you for joining us, and thank you for being here. I know it's late. I know you've had a really busy day. Yes. It sounds like, your first case was challenging.
Yes.
But it's doing what you love, I think, which is rhinoplasty. I know we'll come on to that, but anyway, but thank you very much for being here, given how tired you must be.
Thank you for having me as a guest.
And this podcast is really, the idea is that, we'll probably ramble for 45 minutes or thereabouts. We'll try and talk, first of all, I'll try and talk about you, if I may, and learn about you. And then if we can talk about you and the clinic, because it's a podcast for the clinic. And then we can talk about exactly what it is that you do, your specialties, your surgery, why you do it. Right. And let's see where we go. So, tell me, who are you? Where do you come from?
I'm Mark. I come from Greece, as you know, like the wife. I did my training, my university in Greece, and then I did all my specialty here in the UK, and I finished 16, 17 years ago. And I started working, and I've been working privately in London ever since. Yeah. And
so did you come straight to the UK? You didn't ever practice in Greece, or how long were you there for?
I worked as a junior doctor doing my rural service. And I did military service, which you do in Greece, which was fun, but a little bit too long. But and after that, I came here after the army straight. So I actually started working in Greece for a week doing my general surgery kind of thing. And after a week, I resigned.
Oh, really? How come?
Because I was planning to come to England, and I just wanted my. Basically, you go on the waiting list in Greece to get on the specialty, and the waiting list starts by when you start doing your general surgical part. So I wanted that to start counting, and they didn't really know. So I started, and after a week I resigned. Yeah. I'm like, I don't like it here. They didn't expect it.
And you came straight to the UK.
Yeah.
And then what was your, what did you do? How did you get started in the UK? Because it is, it's not the easiest market, as it were, or business to break into.
No, the main thing is that my kind of referees were kind of unknown in England, so it was difficult to get to put my foot inside. So as soon as I did that, but I started by doing locums here and there, and then I got my first post, and then I got a surgical rotation, and the rest is history.
Which parts? Was it in London always, or
no? It was up north.
Okay.
My surgical rotation was in part of York, basically. I was in Scarborough.
Okay, cool. And then how did you end up in London?
So I did all my training here. I traveled a bit in Greece. Actually, I did do some plastic surgery and some medicine in Greece while I was in the army. So my first experience in plastic surgery was in the army in Greece. So I became a consultant in Sheffield, and I worked there for about 6 months as locum. And then I didn't really want to I wanted to come to Greece. Yeah. So when I finished, and that's why I couldn't really be committed to the NHS full time. So I started working in London in private practice and to get some experience in plastic surgery, basically, because the plan was always to go back to Greece. And then, as it happens, life laughs at you when you make plans.
Yes.
And then in 2010, the crisis in Greece happened. Yeah. And everybody was trying to get out of Greece. Yeah. And I was planning to go back to Greece, but I stopped, basically, and I just stayed here.
The timing was the worst. So why plastic surgery? How come you've always wanted to do plastic surgery?
That's a long story. So first of all, it's quite challenging. So, and I like a challenge. My first choice would have been cardiothoracic surgery. But to cut a long story short, again, I was planning to go back to Greece, and in Greece, if you're a cardiothoracic surgeon, you're most likely to be unemployed.
Yeah.
Because you need a job in a big hospital, and there just are not, there aren't the posts.
That many.
Yeah.
Do people go abroad for cardiothoracic surgery from Greece?
Yes.
Is that what tends to happen?
Yeah.
Yeah.
So I'll tell you a story. So I went to see a friend of my dad, who is like one of the best cardiothoracic surgeons in Athens, and he told me exactly that right now, he said, there is 90 posts for cardiothoracic surgeons, and there is 180 of those around.
Yeah.
The day after, I went out, and I was coming home late at night. The taxi driver, we started chatting, and I was like, so what do you do? Well, how come you're a taxi driver? He said, I'm actually a qualified cardiothoracic surgeon.
Yeah, okay.
And he was working as a taxi driver because he didn't have a job. So anyhow, that took me away from cardiothoracic surgery.
Because we went through something similar in the UK, actually. There were too many trainees for the number of posts. I'm guessing that's because it all turned into interventional cardiology, stents and whatever.
Right.
And so they actually, I think, turned around and said to the trainees, look, guys, a lot of you are not going to have jobs. So we're going to recommend to a bunch of you that you find another specialty to go to. And quite a few of them have come to plastics, I think, because it's a similar skill set with the microsurgery, long operations.
Yes.
So that's interesting. Yeah, okay.
But when I picked plastic surgery, that's the interesting thing I want to highlight, is that was in the mid-90s in Athens, in Greece, and there was no cosmetic surgery that I knew of. Like, I didn't even know that it exists. So when I picked plastic surgery, it was because that was something I could do in an office, affiliated with a private hospital. Also, you could operate from head to toe, anywhere in between, and it was mostly, completely reconstructive. Trauma, amputations, cancers, this sort of stuff. That's what I thought plastic surgery was, which it still is.
Yeah.
I just did not know that I would be doing so much aesthetic surgery.
Yeah. And so aesthetic surgery it's what you landed into because you started doing private practice, because you wanted to go back to Greece as the plan. Okay, no, it's interesting. And then how's your private practice career evolved? Because I know you from our days at Harley Medical.
That's right.
You'd been there for a while. You're one of their busiest surgeons.
You start, and it's more and more common right now. So you start by somebody sponsoring you, like getting you the patients, like an agent, as you know, and you just do more and more and more. The way I see this, like the companies, is like a really big school. Like you have the patients and you learn your trade, basically. Yeah. Simple as that, and you do a lot. Like you do a lot. That's why I've got these numbers, because I just was doing 700, 800, 900 cases a year. Yeah. So it's like a huge number.
So give me an idea of your numbers then. Run me down. How many
right now?
Ish. Yeah. Where
I've
are you
done
at
probably
now?
over 20,000 operations in total.
And so how many noses? How many breasts? How many faces?
It's crazy numbers. Yeah. It's like I've done over 4,000 noses and over 10,000 breasts.
Yeah.
And the rest is a mixture of tummies, faces, whatever.
Yeah.
Everything. Yeah.
It's
like crazy now. Yeah,
I suspect you're probably the most prolific surgeon in the UK. I certainly haven't heard of any.
If I'm not the most, maybe I'm up there.
Yeah, absolutely. And so, we both worked in Harley Med, and I agree with you. It was a finishing school. You've trained. You know where you're at in terms of your technical skills. You're at your peak when you finish your plastics training, but you don't know the business of plastic surgery, how to run a clinic efficiently, make sure you see enough new patients to fill your operating lists, make sure you're seeing your follow-ups adequately without upsetting them, because you can end up getting rushed and not cutting corners. But and then having done that, I mean, you stuck around for a long time with Harley.
I did, because I kind of
did you get comfortable?
I had preferential treatments, I would say.
Yeah.
They had some rules, but because of my results, they were good, and I was allowed to do pretty much whatever I wanted. Yeah. And it was almost like a golden prison. Yeah. In the way that, you have an expensive mortgage, and then you know that at the end of the month you will always have work. Yeah. So I took my time, and I didn't mind it, but I decided eventually to have a bit more freedom and do my own.
Tell me, because that's relatively recently, in the last few years, isn't it?
Like it was about 5 years ago, 4 or 5 years ago.
What made you do that finally?
Because I wanted to do it. Yeah. I just wanted an opportunity. Yeah. And the opportunity came just before COVID. So I started having private practice for a few years. But with COVID, it was just I just started seeing my own patients, and then I just did not have the time to go back.
Yeah.
So I was too busy with my own patients, and it just happened basically on its own, which was great. And I never looked back.
Yeah, absolutely. I mean, I think it's a similar thing with me in that, I mean, I took another stepping stone. I think you did the same as well, actually. Went via Cadogan, and I don't know if you're still working there.
I'm working Cadogan, yes.
And are you, because I went from Harley where they gave me all of my patients. I didn't have any private practice of my own really to talk of. They started coming through.
Yeah.
And then I moved to Cadogan where, again, they were giving me a lot of patients, but my own private practice
I wasn't getting too many, if any, probably was getting maybe one patient a month.
Yeah.
Because I didn't really want the patients, they just wanted me to have some patients, but it's
So you've been in independent private practice ever since. And I mean, you've come here now, obviously, which is great.
Yeah,
how are you getting on? Tell me about working here. I mean, part of what I'd like to get across is an impression to colleagues as to what it's like here.
Yes, I like if everybody listens, come here, you will love it. That's all I have to say. So why? First of all, because of you, because you run the place, and it starts from the head. Because you're a doctor and we're colleagues, and you're a great guy, and everything is just nice. And also it feels like a family. It feels like it's just relaxed, nice. The place as a place is brand new, and it's really well done, and the location is great, and it's going to get even better as it's up and coming because of where it is. And the main thing that was for me the problem was basically the location, because I live in North London.
Yeah.
And that's what kind of stopped me from coming earlier. The distance.
I was trying to convince you that it's not that far.
But it's actually the Northern Line.
Yeah.
So it's the Northern Line. You get from Highgate, where I live, and to here it takes half an hour.
Yeah.
And it's far easier than cycling or driving or anything, basically.
No. I mean, it's great to have you're getting to be ridiculously busy. I think it's certainly your list today was huge. The cases you've done.
Don't remind me.
And so, what do you now see potentially? As where you go from here. What's your next plans? I mean, are you? Because I'm again, one of the things I want to try and get across is why I think it is a good idea to build a place like this to new up and coming colleagues and to colleagues like yourself. Any plans like that to expand?
Well, kind of, not exactly like you. So no, I'm just happy with my private practice, and I just wanted to establish a bit more.
Yeah.
But what you've done here is amazing, but I don't think I have the head for it.
It does.
It takes a lot. So what I'm thinking of doing is at some point is somewhere in North London I'll build a non-surgical kind of clinic, a facial aesthetics. Yeah. Which so not for operating or anything like that, because that is a lot of headaches, I guess. But I want to do something like that. Yeah. So I mean, I don't know how, because I don't really want to do it myself. I want somebody to do it for me.
Well, we can talk. I can, that's the thing is, speak to colleagues, I guess, and speak. There's a few of us who've done it now around the country, and hoping to get some of those people joining us here at this podcast as well to talk about sort of how to build a clinic. But no, great. And
Gary, I've already spoken to Gary, and he's helping me a little bit.
Cool. And so having said all of that, what I also want to get into is, because I really wish you would talk about what you do, the specifics, your actual surgery, certain operations that you are your favorites. So if you tell me, I don't know, for example, rhinoplasty, tell me. Let's talk about your technique for rhinoplasty. What's your rationale? How do you, in very simple steps, if possible, how do you do a nose? What do you do?
Talking about the primary nose, because the nose that I did today were both secondary.
I know, anything that you think. Tell us about your noses, basically. Because I know that you're not necessarily conventional.
No, not at all.
No.
Like I do a lot, as you know, but I do a lot of unconventional things. Actually, a lot of the fellows that come and see me, like they are amazed by what it actually is the result.
Yeah.
But my ways are against kind of many books,
Yeah.
shall we say. But it works.
Yeah.
And if it works for me. So so I do all sorts of noses. Today I did 2 secondary rhinoplasties. I like difficult ones.
Yeah.
Like primary noses, I like them. I think rhinoplasty is my favorite operation,
Okay.
even though I think I'm more known for breast surgery. I like it because it's a challenging operation. It's probably the most difficult operation in plastic surgery, I think. Like more difficult than faces or anything, I think. And you can never find a nose which is exactly the same as the other one.
Yeah, absolutely.
Like it's always. So I was telling the scrub nurse today that every rhinoplasty is like an expedition.
Yeah.
So you start and you don't know exactly what you're gonna find.
Absolutely.
So it's like that.
Yeah, absolutely.
And it's unlike any other surgery that you do really.
And you have to think on your feet.
Yeah. And then he was asking me, "Do you make a plan?" Actually, the fellow that we had today,
Yes.
who's a great guy, he was asking me, "Do you have a plan?" I'm like, "I don't actually have a plan because you have a broad plan of how you want the nose to look like, but you don't actually know how you're gonna get there." For example, today I did one of the nose the first nose that I did was really difficult. It took me 3 hours, and it usually takes me. I'm fairly quick, and it usually takes me an hour to an hour and a half. So for me, that was really long.
Yeah.
But I found stuff that I just did not expect to find because it was kind of in a bad shape, basically, from the previous surgery.
Yeah. This was a revision nose.
It was
had one previous operation?
Well,
At
the
least.
one
You
that
never
said...
know. You never know.
You never know, but it just looked... It was bad, and I knew why the lady wanted to do it. But yeah, it was just... You go in, and usually my experience with noses is that if they look bad from the outside, it looks 3 times as bad when you actually go on the inside.
Yeah,
like the asymmetries are just ridiculous. I take a video because the people don't believe me what I see inside.
Absolutely.
It's like, look.
And is there any particular signature like moves, as it were, or approaches that you do? Not necessarily with these cases, but with a standard primary, for example.
So there is a big thing now with preservation rhinoplasty and structural rhinoplasty and what have you. I always do a structural.
Yeah. This is the almost a traditional.
Yeah, basically a structural septorhinoplasty always. Yep. So I always do a septorhinoplasty because I want to kind of look after the breathing a little bit.
Yeah.
I want to have the freedom, basically, to do whatever I want.
Yeah.
That's the thing, because you open a nose and sometimes it's like, oh, okay. Like, so the patients with a septorhinoplasty, you can take the nose apart and rebuild it, and you can do whatever you want. So that's the main thing with a septorhinoplasty. One thing that I do, which I think I have not seen anybody else doing, as you probably have seen me doing, is basically when it comes to the tip and the domes, and basically I just cut it off. People, they go like, oh my God, what are you doing? But I've done, I don't know, easily over 500 of
using
these.
that technique.
Yeah, and basically I had to revise once.
Okay.
So 1 over, 6, 7, 800.
Yeah.
So that is my revision rate for this particular maneuver.
Yeah.
So it works. It works and it's easy. Okay, so if you have a tip which is out there like Pinocchio's, this takes 5 minutes to do. Well, you can try to deproject it because that's actually also very, when you have the tripod kind of theory of the tip being like a tripod. Yeah. So you can adjust it. So for example, if the tip is droopy, you can remove more of the the lateral crural and the medial crural, so that rotates the tip backwards. Yeah. Or you can deproject it, or you can you can do everything, all sorts. Also, it works for asymmetries. I did it today. So one tip was short, the other was long. So what you gonna do? Yeah. So you have to remove this. Yeah. So you do. So that's it. So I think that's what I do, and I try to inspire confidence to my fellows that come and see me and like, look, this works. Yeah. But then they just don't have, the balls, I guess, to do it.
The thing, we're all influenced by our traditional schools of teaching. Exactly, I guess that's the problem. So, I'm certainly, what I would say is, I remember videoing you when you opened a nose.
Yes.
And I have to say, I have been following that ever since I've been
no.
teaching it to the fellows, saying, this is Mark's way of opening
Yeah,
the
no.
nose. It works. It works. Copy it.
Exactly.
And I mean, it's a great way and a very efficient way of getting into the nose.
So you see what really helped me in the beginning is that when I started working in private practice back in 2007, I was in Highgate Hospital. So Highgate Hospital at the time, 30% of the cosmetic operations of the UK were done in Highgate Hospital.
Wow.
So they were working 364 days a year, apart from Christmas Day. Every other day, including Sundays, they were working. 3 theatres running full lists, at least 8 patients a list. And they were some really good surgeons. So whenever I was not operating, I was in somebody else's theatre.
Yeah, yeah, absolutely.
So this is what this is actually really important for me. I can tell which fellows are going to be good and which won't, because the good ones, they have got no ego, and they just want to learn.
Absolutely. And I think cross-fertilization, visiting, I'm always touring. Yes. I call it, it's like a vicar going around the village. Yes. Doing parish business. It's all right. So what are you up to? I love gate crashing other surgeons' theatres. I'm always walking into yours, and I always pick up something, even if it's a quick 5-minute visit. There'll be something. It's
exactly.
Like, I'll do it that way, or no, I won't do it that way. Whatever. I think that's something that surgeons should never stop doing, is visiting each other. And
when you become bad when you think you're good.
Yeah, absolutely.
When you think you're good, then you stop learning, and then you become bad.
Absolutely, yeah. I think I'm always saying, always be scared.
Yeah.
Never lose the fear.
Yeah.
Because otherwise you'll get complacent and do something stupid.
Exactly.
And actually never do it alone. I think you can't do this business alone. It's work with colleagues, work with good colleagues. Let's move on to your breast surgery. So
I've done a lot, and I think I have a signature operation, which I don't think many other people are doing, or they're not doing to that extent. So my basically it's what I call the opposites attract. So I do a breast augmentation and breast reduction together.
Yes.
So what some people would call augmented mastopexy, I've made it into an augmented reduction.
Yeah.
Why? It's very simple. It comes from experience, because as everybody, you have some results which are suboptimal. So for example, if you put an implant in front of the muscle and everything is heavy, things will drop eventually, even though it will look great for 1 or 2 or 3 years.
Yeah.
And then people will come back after a couple of years and say, I would prefer my breast to be higher.
Yeah.
So anyhow, so for this and many other reasons, I started basically doing my augmentations in a submuscular plane, mostly dual plane 1 or 2. So this keeps the implants higher.
Yeah.
But what happens is that then the breast drops.
Yeah.
So the implant, so the implant doesn't drop, but the breast will drop, and it will cause you waterfall deformity. And then you think, how can I prevent it? Yeah. Well, it's very simple. By actually doing a lower pole reduction there and then.
I do exactly that.
Right. Okay.
And I think I've even sent you one of my unsatisfactory results.
Yes.
And I think you corrected it.
I can't remember.
It was years ago when I was young and stupid.
Yes.
I think a reduction augmentation, which is also what I have to say, I don't tend to do a mastopexy. Do you still do a mastopexy as an operation?
Only when I do a periareolar mastopexy.
Right.
So I just remove the skin and I mobilize the gland, but actually no. So then I don't actually remove any breast tissue.
And to be honest, I do exactly that as well. But I call that a nipple reset almost. Right, it's where you're almost moving the nipple into a better position. The breast is still the breast, and you're just kind of moving it up using like the Benelli egg shape. And what implant-wise, you're always submuscular, or
99.9%, unless there is an implant which is already there, and there is no need for you to change it. I remember this lady that she came and she had a few operations, and the muscle was dual plane 5. So there was no muscle, basically. It was up there, and she did not have any muscle, and she came with terrible rippling. And then I used some B-light implants. So one of the few times where as a private practitioner, when you not work with a company, you're not affiliated with any manufacturer, so you can use whichever implants you think is best.
Yeah, exactly.
Because you have great freedom. I've actually used pretty much every manufacturer, everybody.
Because
and there is a place for everybody. It's like for Negor, Motiva, Sebin, Mentor. I used to use Allergan, unfortunately, PIP even in the past. I've done everything.
And if are you going? I mean, when are you doing a traditional dual plane, or are you doing any?
No, you are doing. I know what you're doing, and you're doing what I've done a few years ago, which works really, really well.
Yeah.
But after you see, I think dual plane is a kind of a fashionable thing again. So not everybody needs it.
Yeah.
And that's something also that a lot of young surgeons, they start and say, oh, you dual plane 2 for everybody. Like, why? So you need to have an indication to do a dual plane because it gives you certain results. So do a traditional dual plane 1 when you just release the muscle in the inframammary crease a little bit. And then when the breast is ptotic and you want the implant to bottom out a little bit, then you do a dual plane 2 and dual plane 3 if you want even more bottoming out. So it's about the degree of bottoming out that you want from the implant. Really.
Yeah. Cool.
So that's how I see it in my head. Basically.
I do the split, but in a similar way, I'll tune the split in according to, I guess it's similar but different,
Yeah.
Let's move on to, I know you do quite a lot of faces.
Yes.
Again, it's everything is deep plane these days.
Right.
So where are you at?
Well, it's not actually. No. So I have done deep plane. I don't think... So let me tell you my rationale.
What's your official?
My rationale is I met Rod Rohrich. You know Rod Rohrich, like he's the godfather kind of plastic surgery back in 2008 in Dallas. And actually had a
the rhinoplasty course, I'm guessing.
At the rhinoplasty and face.
Yeah.
And then so dual plane, so deep plane facelifts is something that's been happening for many, many years. Okay, it's very fashionable now.
Yeah.
Like it's really, really fashionable. And a lot of really good surgeons are doing it and they got exceptional results and it's trending. Okay, but you will have exceptional results with different techniques. Like I can tell you of 5 surgeons that I know that they got amazing results without doing a deep plane. Yeah. So I think the problem with the advantage of the deep plane is that you divide the ligaments, the retaining ligaments, the zygomatic ligaments and everything. But if you just do a plication and you go in front of these ligaments, you will have exactly the same result. I remember Nick Percival. You remember Nick Percival. Yeah. So he was doing a mastectomy, taking the zygomatic ligament. Yeah. So he wasn't doing a deep plane, but it looked exactly like the Giacono kind of facelift. Yeah. Okay, but he wasn't doing a deep plane. So I don't think that the face makes a really big difference in what you do. I think the big advantage of the deep plane is not so much the mobility, because you can get a good mobility by doing a traditional smash plication. I think the big advantage is the kind of degloving of the skin and how much bruising you're going to get, because you have a lot less skin which is exposed and a lot less area which is bruised after the surgery. Less chance of bleeding. So this is, I think, the biggest disadvantage of the facelift, the smash plication facelift, the way we do it, that you have a lot more bruising. On the other hand, we are in the same forums. Okay, the deep plane, St. Louis kind of forum, and you hear people saying that it's actually really, really common to have nerve paresis, like neuropraxia.
Yeah, absolutely.
Okay, so and Giacono was saying that it's actually really common. Actually, I have to say that's something I've never seen, and I've done it a lot. Okay, like I've never seen neuropraxia, and when you have neuropraxia, as you know,
patients are
you cannot sleep.
Yeah, absolutely.
Okay, because you think, is it neuropraxia or is it actually a nerve which is never going to recover? And the patients look like they have a stroke for a bit. So which is better? To have one every 100 patients or 50 patients with like a signs of mini stroke for a few months, or have more bruising? Okay, so this is my thinking, and I'm like, I don't know. I don't know. I can do a deep plane, and I have done a deep plane, but there need to be specific indications. For example, in a very old patient with a very thin skin, so I will do a deep plane there. Okay, or for somebody with I don't know, like whatever other problems. I think the biggest difference is that I am doing a lot more necks now. Because I think this is what makes the biggest difference. Absolutely. So it's not just the face, but it's the neck as well. So you pull it from laterally and you pull from medially without actually doing submandibular glance, because apparently it's hugely overdone. Like from the chat, the St. Louis group, 9 times out of 10 they admit that when they do it they don't actually need it. Okay, and like Andrew Giacono, you know that she actually very rarely does one, and he's one of, I think he's probably the second most expensive surgeon on the planet.
Yeah, absolutely. Who's the first? You?
Novak. You know this guy Novak in Los Angeles. That's the $500,000 facelift. $500,000.
Wow.
Yeah, I know.
One day, let's see.
One day, yeah.
One day the UK will catch up. Maybe.
But that's my thing. As with everything in my surgery, I kind of try to think why I'm doing things, and kind of to deconstruct
case
it.
by case.
Like no, just like there is a reason behind my madness. Like why am I doing something? Because so why am I doing a facelift this way and not the other way? Yes, it's very simple, basically. Because I want to sleep at night mostly.
Absolutely. No, that's great. Is there anything in particular, that you wanted to bring up and talk about? Because there might be. Have I left something? I'm sure I've left something out.
No, I want to say something in one kind of a more general term, because I think we're in the same pot together.
Yeah.
So we both don't specialize in something.
Yeah.
We are masters of many trades, basically, and we're pretty good at everything. And it's difficult in this day and age to market yourself as a master of all trades.
Yeah, absolutely.
Because now people say I'm a face specialist, or I'm a nose specialist, or I'm a this and that and the other, and it's like, okay, I'm a specialist of everything, but it's difficult for people to believe you when you actually do that.
Exactly. They think you're a master of none kind of thing.
Yeah, it's
That's
like, it happens.
I think that the thing is, I am now probably restricting myself to breast surgery and above. I'm not doing many tummies and bodies. I've never done many body stuff, and I've never been a big fan of liposuction, but I'll do it. As part of it. It's not my favorite operation, but having said that, I do tummies in the NHS because I do a lot of abdo wall reconstruction. But you're right. I think I wish the reason I did plastic surgery
because you can operate on anything
is because it's the closest thing to old general surgery, as it used to be. Because the general surgeons before the CT scanner would operate head to toe. They would explore, they would improvise, which is what you've talked about.
Yeah, totally.
And it sounded like really good fun surgery, but the CT scanner, I think, ruined that all, because now you know the answer before you go in, or you don't go in because the CT scanner tells you. And so plastics, therefore, seemed like the closest thing to general. And that, you're right, I think even now in my practice, the temptation to suddenly start super specializing, not the temptation, the pressure is always there.
It is.
Because I find myself thinking, maybe I should just sell myself as just a nose surgeon, or just a face surgeon, or just a breast surgeon.
I think I can understand the guys that just do the face, because there is a few surgeons that you can do the face, like noses or faces and eyes and whatever. But there are people that just do one operation, like a facelift or just a rhinoplasty. And I'm like, that is the reason I did not become a dentist.
Yes.
Like I just don't want to do teeth all my life.
Exactly.
I want to do something else,
Yeah, I think and I think my biggest fear in life is boredom.
Yes.
I don't like the thought of being bored doing the same thing over and over again, because then I may as well have become a factory worker or something, or and life would have been simpler. But absolutely, I totally agree with you. I think, and I think you're also probably, there aren't many general plastic surgeons left. I kind of think
it's becoming worse and worse. It's becoming worse and worse because the guys that are coming now and they're seeing where this is going, and also it's another thing. It's expectations of the patients. Yeah. So something that you thought it was acceptable 20 years ago is not acceptable anymore. Things
are evolving. Yeah, absolutely.
The results need to be better and better and better.
And
so
patients
you need to be
are getting more and more educated, which is good.
So if you need to have good results, you actually need to be really good at what you do, and you won't find many that are really good doing everything.
Absolutely,
it's the fact.
No, thank you. No, that's well. I'm just a little bit conscious of time.
Right.
I don't want this to. So I'm going to sort of first of all, thank you very much for doing this.
My pleasure.
And thank you for coming here. And but before we wind up, my final question is, if you were going to do something different with your career, what would you do? Is there anything you would change?
I wouldn't become a doctor.
Yeah?
No.
Really? What would you have done?
I would carry on and doing what I really like doing, which was computers, actually.
Yeah?
Yeah.
So you become a computer
So I wouldn't be a millionaire, I would be a billionaire.
Absolutely, yeah. I thought about computers, but I knew that I wouldn't be any good at it. I was not very, I don't think I would have made a very good IT.
I really liked it, actually.
Yeah, I enjoy it. I still enjoy it. I like a gadget. Yeah. But no, thank you. So maybe we'll come back. Perhaps you'll have taken up a retirement project or something, and we can bring you back. But thank you very much for coming.
Thank you.
Thank you for watching, everybody, and we'll see you at the next one. Thank you very much.